Takes time.
Matt, you're ready?
You're good.
Okay, perfect. All right, so get started on our talk of non-CF bronchiectasis. We'll talk about sorry, let me just. All right, so we're going to talk about introduction, try to classify the different forms of radiographic and different presentations of bronchiectasis, the epidemiology, the pathogenesis, and talk a little bit about this concept of the vicious circle and microbiology. And then we'll talk about, very importantly, the associated disorders, predispositions, then how to make the diagnosis, what to look for, and then lastly, we'll talk briefly about management. So to start, I'll start off with a question, and anybody can volunteer to answer, but I'll go ahead and read it. A 60-year-old plumber comes to you with cough to brownish plugs, mild exertion dyspnea, low-grade fever, periodically. Recall that several years ago he mulched his yard and he apparently inhaled dust from this material. Noting the next he had a cough and generalized lassitude, and over time he has continued to experience shortness of breath, significant exertion. His cough was worse in the morning, conducted mostly clear white sputum with occasional thick plugs. He reports no hemolysis, weight loss, and night sweats. He reports having a history of asthma, but he grew out of it. He's a lifelong non-smoker. His 3 school-aged children have been in good health, and there is no family history of respiratory conditions. On exam, his vital signs are blood pressure 183, heart rate 69, temperature is 97.2, oxygen saturation is 96% on room air, and his lung auscultation reveals mild inspiratory rhonchi bilaterally and no decreased breath sounds. CT and PFTs are here. So these are the thick mucus, brown mucus plugs that he was able to cough up. This is his CAT scan, where you guys can see. Can you guys see my arrow, by the way?
I can see your arrow, but it looks like you're still on the outline slide.
Oh, really?
I think go back to the power. Yeah, there you go. It's moving now.
Wait, so
maybe if you go back to slideshow, you can use the.
Let me share again. 1 second. Sorry. You guys heard the question at least? Now, yes. Can you see the slides?
Yes.
Okay. So anybody want to tell me what they see here on the CAT scan of the chest?
There's some.
So here you see these central bronchiectasis. And then over here, you see these, thick mucus-plugged airways, branching tubular opacities. And then this patient had breathing. This is all from Seek, by the way. So he had PFTs, and you could see that his FEV1 is reduced to 69%, and the FEV1 FVC ratio is reduced to 64%. And there's no real significant bronchodilator response. His total lung volumes are total lung capacity is normal, and his residual volume was a little bit higher than expected, 3.48 liters, 145% predicted. So the question goes on. Lab testing reveals hemoglobin of 15.5, hematocrit 46, white count of 7,900, with 4,900 neutrophils, 2,300 lymphocytes are 729, monocytes 90. And then lastly here, most importantly, eosinophils were 1,450. Serum transaminase levels were normal, creatinine's 1.3, IgG level is normal at 1360, and IgE is 7,840. So pretty straightforward question, but it's important for us to recognize this. So which of the following is the most likely diagnosis?
It's HDMI1, I think. It'll show you the
Anyone want to take a shot at it?
ABPA.
ABPA, yes. All right, very good. So let's talk about what bronchiectasis is, and we're going to talk about all these different forms of bronchiectasis soon. But bronchiectasis is a syndrome. There's many underlying etiologies, and it's associated with ectasia or irreversible dilation of the bronchi. with destruction of one or more bronchi and associated with inadequate clearance and pooling of mucus in the airways. Usually represents either as recurrent disease or chronic sputum production or refractory episodes or exacerbations with usually due to infections. Secondary manifestations can include hemoptysis, chronic airflow obstruction, especially, for example, in alpha-1 antitrypsin or in ABPA, progressive dyspnea, and then I didn't realize this, but back in the day before the antibiotic era, so in the pre-antibiotic era, there was a lot of cases of secondary amyloidosis and embolic brain abscesses, which I thought was very interesting. So a lot of the slides and information I got from the Murray-Nadel chapter on bronchiectasis, and then from the BTS and ERS guidelines, which were very helpful. This is the first table in Murray-Nadel's, and it goes over all the different conditions associated with bronchiectasis. So whenever I look at bronchiectasis, I always first differentiate between cystic fibrosis and non-cystic fibrosis bronchiectasis. And then after that, you want to differentiate what is the underlying etiology if it's non-cystic fibrosis bronchiectasis. And although majority of the time, or at least half the time, it's probably going to be idiopathic, you want to make sure you're not dealing with some specified form in which treatment can be targeted to the underlying pathology. So, we divide it into post-infectious complications, primary immune disorders, so hypogammaglobulinemia, common variable immune deficiency. Always want to check to see if there's findings consistent with alpha-1 antitrypsin. Rarely we'll see these heritable structural abnormalities. And then very importantly, you want to make sure there's no underlying autoimmune or inflammatory process. Lastly, here you see the inhalational obstructional. These are more localized or focal bronchiectasis. And then also very importantly, allergic bronchopulmonary aspergillosis. Every patient that has bronchiectasis, it's important to rule out ABPA, whether checking IgE, CBC with eosinophils, and IgE to aspergillus, and other testing, CAT scan, et cetera, if necessary. So, whenever you look at bronchiectasis, we know that infection is is common. They get recurrent exacerbations. And one of the important questions is to identify whether infection is the incidental event or an episode that does not reflect the patient's intrinsic host defenses, or is infection secondary to an underlying predisposing condition. So if infection is what causes the bronchiectasis, this is, for example, patients who have bronchiectasis due to childhood pneumonia or childhood tuberculosis or recurrent childhood infections. Or this is when you see the localized or focal bronchiectasis due to foreign body obstruction or endobronchial tumor obstruction or extrinsic airway compression. Then there are other patients that develop bronchiectasis because of their underlying predisposing conditions. So CF being the prototypical type, but other immune deficiencies, heritable structural airway abnormalities, and then the inflammatory autoimmune and alpha-1. And then the key question here is infection the proximate cause of bronchiectasis, or does infection develop because of an underlying predisposing condition? And this question is helpful in predicting prognosis, management, and identifying the etiology, and that's very important in managing these patients with bronchiectasis. So let's move on here and talk about the radiographic classification. So I'm going to share this PowerPoint with you. It's a lot of slides, but it's mostly pictures. And I think seeing a lot of pictures of bronchiectasis and the different types is helpful in kind of being familiarized and seeing patterns is very important. And when we look at bronchiectasis, there's three major patterns. There's cylindrical bronchiectasis, which is kind of this tubular pattern. And when you look at it in a cross section, you might find the classic signet ring appearance. And then there's the second most common is the cystic bronchiectasis, which is kind of what we call like the bunch of grapes or the cluster of grapes sign. And then lastly, there's the varicoid or varicose bronchiectasis, which is the least common radiographic form of bronchiectasis. So let's talk about cylindrical first briefly. We talked about it's tubular. On cross section, we see the signet ring appearance, and it's really failure of the involved airways to taper progressively in their distal course. And the airway might be visible within a centimeter of the pleural surface. And usually the bronchial walls are smooth and regular, as opposed to, for example, in varicoid bronchiectasis. Here we talk about the tram track sign. And here are some pictures. So here's a classic signet ring sign. Here's the the artery, and here's the airway surrounding it. And you want to look for an increased bronchoarterial ratio. Here's the classic tubular appearance of bronchiectasis. And these are, the tram tracks. See these parallel roads over here, and you see the airway is the bronchi are very smooth. There's, not as much thickening. This is a nice picture here. You see the signet ring, and you see these nice diamond rings. And this is classic of cylindrical bronchiectasis. And then the tram track sign, right? So you see these nice dilated airways go all the way out to the periphery within 1 centimeter of the pleural surface. The second form is cystic or saccular bronchiectasis, where there's focal or cystic distortion of the distal airways. And again, you see these focal or cystic distortions or dilations or outpouching of the airways, and they extend all the way to the pleural surface. They may be isolated, they may be confluent, and a lot of times you'll see this as a bronchiectatic consolidation with associated volume loss. And sometimes you'll even see air fluid levels. So here's a nice example. Here's these little outpouchings of the distal airways, cystic in nature, and you can see. Sorry, I don't see. Can you see the arrow that I'm pointing at?
Yeah.
You can't see my arrow. Okay,
Yeah.
Good. So you can also see, like these little focal outpouchings. And one of the key questions to answer is this cystic lung disease or is this bronchiectasis? And one of the ways to tell is does it extend from an airway? And so you could see that these bronchi, you could see the airway here, and then these focal outpouchings of the distal airways. This is cystic bronchiectasis. These are nice examples of what we refer to as bunch of grape signs. So you see all these cystic dilations of the airways all over. And you can see here that bronchiectasis can be unilateral. You want to see it extending to the pleural surface. And in areas where there's bronchiectatic consolidation, you want to look for associated volume loss. Another nice example in a coronal film of this cluster or bunch of grapes sign that we described. Here's just more example. This is actually a case that I believe I saw with Andrew a couple of weeks ago. This is a youngish guy, maybe in his early 50s, with a history of heavy smoking, marijuana, and he was also a steel grinder without wearing a mask. And he has this, interesting, cystic saccular bronchiectasis, all these outpouching. You could see here that maybe development of some air fluid levels in these outpouchings of the airways. Here's another example of a cystic bronchiectatic consolidation. This is the more typical syndrome that you guys will see more regularly, especially if you around with Dr. Steinberg or Dr. Singas. I know they see a lot of these chronic non-tuberculous mycobacterial patients, and you see these coarse cystic process. You see it in the middle lobe, in the lingula. Here you can see it very classically in the right middle lobe, and the adjacent lung architecture is destroyed, although the remainder of the lung is relatively normal. And when you see this in the right middle lobe and the lingula, this is classically associated with MAC lung disease or other non-tuberculous mycobacterial lung disease. The last form of bronchiectasis is varicoid bronchiectasis. It's the least common form. And you see irregular dilation, narrowing, and outpouching of the airways. Essentially, I think about it as traction bronchiectasis without the associated interstitial lung disease. You look for the beaded appearance of the airways with interspersed areas of relative narrowing. The fact that the underlying lung parenchyma is normal helps to differentiate varicoid bronchiectasis from traction bronchiectasis. So here's a nice example, these varicoid bronchi with relatively normal lung underneath, right? And you can see here areas of mucus plugging as well. Again, here's a nice demonstration over here, this varicoid bronchiectasis. Some people refer to it as the string of pearls sign. You can see this beaded appearance of the airways, and it's not due to traction, but it's due to actual primary, bronchial or bronchiectasis, and not a secondary process. And that takes us to the last form of bronchiectasis, which is traction bronchiectasis, which is really not a primary bronchiectasis. It's a secondary process where the airways are irreversibly dilated because of distorted underlying lung architecture. And this is classic with pulmonary fibrosis and interstitial lung diseases. And essentially, the bronchi are pulled apart by traction of the surrounding parenchymal fibrosis. We said it's seen in interstitial lung disease. So this is actually a patient I have who has idiopathic pneumonia with autoimmune features, who has on who we're treating right now with, he's on chronic prednisone and he's on nintedanib therapy. And you could see these dilated airways, the traction bronchiectasis, and the traction is secondary to the underlying parenchymal lung disease, not a primary process. These patients with traction bronchiectasis don't have the classic recurrent infections and sputum production as the other bronchiectasis patients. So what are the other ancillary radiographic findings in patients with bronchiectasis? This is a patient we'll talk about more later, but you could see here that he has bronchiectasis in the lingula, but also you see here in the right lower lobe this, these branching tubular opacities and mucus plugging. And whenever you see this, a lot of any form of bronchiectasis can cause this branching appearance, but classically you want to think about ABPA. And primary ciliary dyskinesia, cystic fibrosis, et cetera, can cause this pattern. Other findings, you want to look for bronchial wall thickening. So you can see how this airway here is very thickened compared to other bronchiectatic airways. And then also, if you notice here, you'll see that there's this what we call mosaic attenuation. You have areas that are normal, and then you have these hyperlucent areas that are abnormal. So here's a normal area, and it's right next to it is this abnormal hyperlucent area. You can see it a little bit better here. You see this normal lung here. This is what we call mosaic attenuation, and then the hyperlucent areas represent air trapping. Lastly, patient can have secondary pulmonary hypertension, and then also look for development of mycotomas or aspergillomas in these bronchiectatic airways. All right, so another form of classification, so we talked about the radiographic classification. Another form of classification is wet versus dry. So most patients that we see with bronchiectasis will have the wet classification, where they're continuous or frequent productive cough, they have copious purulent secretions. Classically, these patients have been described in the dependent lung zones, so lower lobe involvement, right middle lobe, lingular involvement, and it may be related to pooling of secretions in these dependent regions of the lung. Contrast this with the dry phenotype, which can be rarely associated with cough. If cough is present, it's non-productive. And this is classically in the upper lung zones. Of course, the big exception to this is cystic fibrosis, which does have an upper lung zone predominance. But some people like to have the wet versus dry classification. So just talk about the epidemiology. I'll do this very quickly because I want to focus on the predisposing conditions. But we've definitely seen a decline after antibiotics were introduced. And it's likely that antibiotics have decreased the frequency, severity, and duration of lower respiratory tract infections that might result in bronchiectasis. Although recently we have seen increased rates of non-tuberculous mycobacteria. And because we're using CTs more frequently, we are seeing recently an increased rate of detecting bronchiectasis. Pathogenesis, again, I want to talk about this briefly just because I want to focus on the other concepts. But if you think about the normal lung, the airways are held open by a combination of negative intrapleural pressure and the cartilaginous rings of the trachea and the large and medium airways. And the distending forces of the negative intrapleural pressure are then transmitted to the airways. And this is a diffuse system of interstitial tethering. And so we see the pathogenesis is related to three different mechanisms: traction, which we talked about already, and then propulsion bronchiectasis, which is kind of the mechanism I want to talk about more today. And essentially here, there's an intense inflammation originating in the lumen of the airways. Classically, we see this in ABPA. There's an intense immunologically mediated reaction, for example, to the inhaled aspergillus, and you develop these mucoid conglomerates, mucus plugging, fill the central airways, and then this causes secondary bronchiectasis. The third mechanism is the weakened tensile strength of the airways. But before we do that, I just want to, I think it's important to see a lot of images. Here that the classic ABPA tubular branching opacities with thick mucus filling these dilated bronchi. And you see on the mediastinal windows, you see increased attenuation, and that could be because of the mucus impaction may contain calcium, may contain metallic ions, but it's a very dense mucus plugging of the airways and creating this, very characteristic mucus plugging branching tubular opacities. So the second mechanism is the weakened tensile strength. And this is classic with post-infectious bronchiectasis. You have damage to the airway walls. This results in loss of the structural integrity of the airways. This leads to scarring, loss of lung volume, affecting the adjacent parenchyma, and then leading to regional increases in retractile forces. You could also have this with primary weakness of the airways. So for example, in the rare cases we see of Munir-Kuhn's, congenital tracheobronchomegaly, or Williams-Campbell, which I've never seen a case, or Marfan's relapsing polychondritis, you have primary weakness of the airways leading to weakened tensile strength, which results in recurrent episodes of infection and then leading to bronchiectasis, chronic bronchiectasis. It's usually diffuse. And this, amplified airway compressibility impairs the cough mechanism. That's really a big pathogenic mechanism to why these patients develop bronchiectasis. And that takes us to the vicious circle. And this is, the vicious circle concept of bronchiectasis. Recurrent sustained infection that causes inflammation in the airways, in the bronchi and the bronchioles, that leads to an intense neutrophilic infiltration, which leads to further injury, decreased ability to fight infection, and a susceptibility to certain microorganisms, such as Pseudomonas, because of the creation of the biofilm, environmental mycobacteria like MAC, and then environmental molds like Aspergillus. And the neutrophilic infiltration is so important in bronchiectasis because the neutrophils, the bacterial load in the airways, causes the neutrophils to cause inflammatory reaction. And then the neutrophils themselves contribute to the damage by releasing neutrophil elastase, metalloproteinases that cause more damage to the airways. We know that in primary ciliary dyskinesia or Cartageners, you have these dysfunctional cilia, and that contributes to the airway inflammation and the colonization of the airways with bacteria, and insufficient clearing of the microbes. And again, that causes the neutrophilic infiltration and the damage to the airways because of the inflammation that occurs. So neutrophil elastase is very important in the pathogenesis of bronchiectasis, and it can cause more ciliary dysfunction, mucus gland hyperplasia, increased mucus secretion, inability to opsonize or kill the bacteria, and can impair mucociliary clearance. And then on top of that, the neutrophils themselves have to die. So these necrotic neutrophils then cause more inflammation. So it's this vicious cycle of damaged airways, which are vulnerable to infection, leading to more airway damage. And it's a self-perpetuating cycle of infection and inflammation that leads to the bronchiectasis. I'm going to skip this slide because I'm not going to pretend to understand this little cartoon of neutrophil elastase leading to the airway damage. But I like this. This is from the Australian bronchiectasis website. And you see the initial infection causing inflammation, neutrophil enzymes, impaired mucociliary clearance. This leads to the airway mucus hypersecretion and obstruction, leading to recurrent bacterial colonization infection, and then bronchial dilation, airway destruction. And this is, the classic vicious circle of bronchiectasis. So then we know that these airways are colonized with bacteria, but we have to realize not all patients are persistently colonized with bacteria. And a lot of times they're intermittent in many patients. Very interesting to note, and this is important for managing these patients, is that patients often remain colonized with the same bugs during stable disease and during acute exacerbation. So if you have somebody with bronchiectasis who has known colonization with MSSA or with a certain strain of Pseudomonas, it's important to know that so that when they do develop an exacerbation, you can modify their antibacterial therapy to what they're known to be colonized with. Of course, doing serial sputum cultures to monitor, because you always want to titrate your antibiotic regimen appropriately. We know, you guys know about this, the common bacterial pathogens. We see, Pseudomonas, of course, but we see strange, organisms that we don't see regularly, like Stenotrophomonas, Acinetobacter, Achromobacter, etc. Very importantly, and this is always on the boards, colonization with Pseudomonas is a bad prognostic sign. These patients have lower FEV1, they have increased exacerbations, they have higher mortality. And that's why there's a lot of research dedicated to, one, eradication therapy, secondly, chronic inhalational therapy with anti-pseudomonal antibiotics. Pseudomonas is harmful to ciliary function, formation, it leads to formation of these biofilms, and like we said, the worsened lung function and quality of life. Another important point is, I always just think that non-tuberculous mycobacteria are a secondary phenomenon, that they just colonize these bronchiectatic airways, which is true. But it's also important that, and we'll see this more frequently now with our, right middle lobe lingular non-tuberculous mycobacterial infections, is that non-tuberculous mycobacteria can actually cause the bronchiectasis there. It can be a primary infection causing the bronchiectasis in these patients. All right, so this is kind of the crux of the talk, which is the associated disorders and predispositions. And again, I want to concentrate on non-cystic fibrosis. And we talked about this. You want to rule out, and you want to evaluate, is there, post-infectious? Is it related to immunodeficiency, alpha-1 antitrypsin? Is it inflammatory autoimmune mediated, or aspiration, acid reflux, or gastroesophageal reflux related? So first, we'll focus on lung injury due to acute infection. And here you see irreversible airway damage due to lower respiratory tract infections in a previously normal lung. It's relatively uncommon now with antibiotic use. You want to ask these patients if they had recurrent childhood pneumonias. And traditionally, you'll see this, we see this very commonly, for example, with patients who had a history of TB. But in the past, whooping cough that was not able to be treated with antibiotics, staph, strep, even adenovirus or history of influenza can cause this. And then, of course, like we know, non-tuberculous mycobacteria, and then anybody who had a severe pneumonia, necrotizing pneumonia, or lung abscess can have secondary bronchiectasis from the acute insult. This is a patient we saw about a month ago. This is a young 40-year-old female. She immigrated from Uzbekistan at age 7. She said that when she was 6 years old, she had a prolonged pneumonia with pleural involvement, and she was hospitalized for several months. We think she probably had TB. Now she presents with recurrent episodes of large volume, could fill 1 to 2 cups of blood. This occurs about 1 to 2 times per year. Her quant gold was positive, so we bronched her. Bronch was negative, AFB was negative, but she did have on her sputum culture, she had pseudomonas. And what you see here is in the right lower lobe, in the superior segment, you see focal bronchiectasis. And this is likely a sequela of her pneumonia that she had when she was a child. This is probably an ideal candidate for resection if she continues to have these recurrent episodes of hemoptysis or bronchial artery embolization, but she's yet to follow up, actually. So the other thing you want to rule out is a lot of times we'll see these adult patients that have adult onset cystic fibrosis. It's not very common, but it's definitely common enough that we see it. And there are certain CF variants that may not present in childhood and may present in adults with bronchiectasis. In fact, it's been studied in adult patients with bronchiectasis from MAC lung disease or other non-tuberculous mycobacteria. About 10 to 15% were found to have abnormal alleles of the CFTR gene. And although most of these were heterozygous, still it's important there may be an association between heterozygous carriers and bronchiectasis with this non-tuberculous mycobacteria. 2% were homozygous, had 2 abnormal alleles. And the mean age of these patients was 61. Like we said, a lot of these patients, although heterozygous, they had classic features of cystic fibrosis, including the airflow obstruction, the sinusitis, the infertility, and infection with typical pathogens. Some case reports report up to 50% of patients with bronchiectasis or non-tuberculous mycobacteria have at least one CFTR mutation. And like we said, I think it's important to understand that we don't know, but there is a theory or a possibility that heterozygous anomalies in the CFTR gene can act as a predisposing factor for bronchiectasis. I don't want to talk about Young syndrome because this was described in the 1970s, I believe. And these patients looked like cystic fibrosis. They had bronchiectasis, they had sinusitis, they had infertility, but they had relatively normal cilia with decreased mucociliary clearance. And it was postulated that this could be poisoning from mercurous chloride, which is no longer available. But now they're saying some cases may have been previously diagnosed as Young syndrome, may actually have been cystic fibrosis now that we have the more comprehensive genetic testing. So going on to another form of bronchiectasis is disorders of immunity. This is where you want to look at your immunoglobulins. So the most common that we'll see is acquired hypogammaglobulinemia or common variable immune deficiency. In these patients, their B cells fail to differentiate into antibody-producing cells. And so you'll find them vulnerable to encapsulated bacteria, strep pneumo, H. influenza, staph, or Pseudomonas. and they get recurrent infections resulting in bronchiectasis. So these patients, in fact, the guidelines now recommend all patients with bronchiectasis, you want to check, an immunoglobulin panel, IgG, IgA, IgM, and of course, we talked about IgE for ABPA. And you want to look for low IgG and absent or very low IgA and normal or low IgM. Another thing that's very important and is part of the diagnostic criteria is that these patients are unable to produce antibody response after vaccination. So, for example, you'll give them the 23-valent polysaccharide pneumococcal vaccine, and then 48 weeks later, you check their antibody titers, and they're unable to produce appropriate antibodies to strep pneumonia. Notice that you may have selective antibodies that may be deficient, for example, IgG2 and IgG4. And then, although the hallmark of therapy is going to be IVIG, there's a subset of patients with CVID who may have, for example, a selective deficiency of secretory IgA that may not respond to IVIG therapy. Other disorders of immunity that can happen are hyper IgM or hyper IgE syndromes. Dr. Steinberg was telling me about a patient he has with Job syndrome, hyper IgE syndrome with severe bronchiectasis. Other ones include the George. They're very rare. We don't, honestly, we don't really see these that often. Dr. Steinberg, has a subset of patients that he sees regularly with some of these conditions. So here's an example of a patient with common variable immunodeficiency with multifocal areas of, this reticular opacities and associated bronchiectasis from recurrent infections. Here's sorry, I didn't want to give you the diagnosis, but here's another form of bronchiectasis, and I gave you the diagnosis, but one of the things you always want to look for when you see bronchiectasis, you want to look at the underlying lung architecture. Whenever you see this pan-acinar emphysema pattern in somebody who has airflow obstruction on PFTs, it's important to rule out alpha-1 antitrypsin deficiency. Sorry, one second. Oh, sorry. No, I was. So, alpha-1 antitrypsin deficiency is known to predispose to bronchiectasis. Whether there's true deficiency or just a heterozygous phenotype, alpha-1 antitrypsin anomalies can predispose to lower respiratory tract infections and it can predispose to bronchiectasis. Very importantly, majority of patients who have alpha-1 antitrypsin deficiency, greater than 95% who have the PIZZ phenotype will have bronchiectasis on CT. And of these 95%, about 27% of them will have clinically significant bronchiectasis with the chronic sputum production and multiple bronchopulmonary segment involvement. You want to look for, again, like we said, pan-lobular emphysema in a young adult with obstruction on PFTs. If you see that pattern, then definitely checking an alpha-1 antitrypsin level and phenotype is very important. A little word about COPD and bronchiectasis. There's a high prevalence of bronchiectasis in patients with moderate to severe COPD. And this is possibly due to increased use of high-resolution chest CT. And it's important in these patients with COPD and bronchiectasis, like we said, to check alpha-1 antitrypsin levels and phenotypes. These patients who have concomitant bronchiectasis and COPD are known to have increased bacterial colonization of the lower airways, more severe COPD, a lower FEV1 FVC ratio, and higher mortality. So it's very important to recognize these patients because it's if, for example, they're colonized with with Pseudomonas or other pathogens, helping to treat that can improve their quality of life, can improve their exacerbations, and decrease their bacterial colonization. So here's a question. I don't know who's with us or who wants to take it on, but I'll read the question. A 24-year-old man is referred to for recurrent sinus and pulmonary infections. His infection started in adolescence with otitis media, sinusitis, and bronchitis. He remembers receiving multiple courses of antibiotics with improvement of symptoms, and he would return to baseline. Occasionally, he would have symptoms that would resolve without antibiotics. He has received all his vaccinations, has not traveled, and has no sick contacts. He's adopted that does not use tobacco, was recently admitted to a local hospital for pneumonia where sputum culture grew rhinovirus and Staph aureus. On physical exam, he's afebrile, 37.2, blood pressure 110/75, heart rate 82, respiratory rate is 22. He has tenderness over the left maxillary sinus and a serous effusion behind his left tympanic membrane. Lung exam reveals coarse bronchi bilaterally. He has prominent right-sided heave on cardiac exam. His cell counts, chemistries, and levels of liver function enzymes, amylase, lipase, and IgE are normal. His spirometry shows FEV1 of 2.36 liters, which is 63%, and FEVC that's normal at 87%, and a ratio that's reduced at 62%. Here's his chest X-ray and the CT from this patient. So I don't know who's with us or who's wanting to look at this CAT scan and read it. But you can see here these dilated airways. You can see the cystic bronchiectasis here in the right lower lobe. Let's talk about what is this patient's diagnosis? I don't think I can hear anybody.
Primary dyskinesia.
Say it again.
Oh, it's highlighted, but this is Cartagener's ciliary dyskinesia.
Yes, thank you,
It's
Fiore. So
dextrocardia.
this is Cartagener. So say it again,
The
Fiore.
guy I sent you. Yeah.
Yes, I'm gonna show his imaging. Thank you, Fiore. So let's talk about primary ciliary dyskinesia briefly. If you look at the ciliary structure, I don't want to talk too much here because our time is running out. But the ciliary structure consists of these 9 microtubule doublets. They're connected to each other by these Nexin links, and they're connected to the central single microtubules by these radial spokes. And the orientation of the central microtubules helps define the axis of the beating cilia. And so, primary ciliary dyskinesia is a congenital structural functional disturbance of these ciliated epithelial cells. And its deficits in whether it's in the microtubules or in the peripheral or in the central or in the radial spokes or in the Dynein arms. I forgot to show you the Dynein arms. These little arms that are on the outer or the inner. Any of abnormalities in these will cause this ciliary dysfunction. These patients are associated, like we said, with bronchiectasis, upper respiratory tract involvement, sinusitis, they notoriously it's lower lobe involvement. And the reason is because there's this organized beating of the ciliated epithelial cells or even gross immotility. So this is the patient that Fiore sent to me about maybe a couple of months ago. Young guy, about 20 years old, who had presented with hemoptysis. He had a chest X-ray that looked like this with dextrocardia and situs inversus. You can see the gastric bubble on the right side and the liver on the left. Or, the left diaphragm is higher than the right one, so he has situs inversus, dextrocardia. And on CAT scan, here are several images. You can see the heart, the dextrocardia. You could see the liver on the left. You could see the bronchiectasis here in the lingula. And you could see bronchiectasis with mucus plugging and these branching opacities here in the right lower lobe. And this, like we said, is Cartagener syndrome, which is primary ciliary dyskinesia with situs inversus. And I didn't know this. I don't know why I didn't know this, but apparently with primary ciliary dyskinesia, 50% of patients will have situs inversus and 50% will not. And the reason is absence of normal ciliary activity during embryogenesis will result in random organ orientation. So this is a syndrome where you might have monozygotic twins, and one of them has PCD and the other has Cartageners with situs inversus, which I thought is interesting. Of course, the classic triad here is situs inversus with chronic sinusitis and bronchiectasis. Here's another image. I just like to put a lot of images here, but you can see the classic cystic bronchiectasis over here, and then other areas of bronchiectasis and mucus plugging, mucoid impaction with the dextrocardia. I want to maybe not talk too much here just because of the time, but you want to look for otitis media, mastoiditis, sinusitis, bronchitis. Classically, look for colonization with Haemophilus influenza, and its lower lobe and middle lobe and lingular involvement is classic. Electron microscopy is the hallmark for diagnosis. I'm going to skip this. I'm going to give you guys all the slides, don't worry. So other bronchial cartilage or elastic fiber defects. So these are patients that have heritable structural abnormalities, Munir-Kuhn's being the one that we'll see occasionally, congenital tracheobronchomegaly. And essentially, you have atrophy or absence of the elastic fibers and the smooth muscle of the large airway. So you'll see tracheal megaly, you'll see central, the main stem bronchi are excessively dilated, and you'll see associated bronchiectasis. Dr. Steiner was telling me he had a patient that had diverticular outpouchings in the trachea, resulting in a large abscess. So these patients can develop these tracheal diverticular outpouchings because of atrophy of the connective tissue between the cartilaginous rings. And of course, more advanced disease results in severe airflow obstruction from airway collapsibility. Some people use the cutoff of 2 to 2.5 centimeters. Other people use the cutoff of 3 centimeters. And the possible therapies include CPAP and the bronchial stents, and of course, lung transplant. Here's a classic case of this very, very severely dilated trachea, more than 3 centimeters, with associated bronchomegaly, like a dilated bronchi. And you can see it here on the X-ray how dilated the trachea is. Here's another patient with this severe tracheomegaly, dilated bronchi, and then associated bronchiectasis. Another syndrome is Williams-Campbell, and this is, I guess, more rare. I've never seen it, but Williams-Campbell is essentially associated with cartilaginous deficiency in the segmental and subsegmental bronchi. So these patients will not have tracheomegaly, they'll not have central bronchiomegaly, but they'll have segmental and subsegmental bronchomegaly with associated bronchiectasis. And these patients classically have this, with inspiration, there's ballooning of the airways, and with expiration, there's excessive airway collapse, leading to recurrent infections. Here's another example of this is a patient who had a single lung transplant. So here you see the transplanted lung, and then here you see the abnormal lung with the bronchiectasis. So let's talk about connective tissue abnormalities briefly. One that we don't see as commonly, but there's an association with the non-tuberculous mycobacterial infections is Marfan syndrome, which is a mutation of fibrillin 1. These are patients that are long, narrow framed, have long fingers, hyperdistensible joints, aortic root disease. And these patients, you want to look for associated lung involvement. So classically, we'll hear about these patients having spontaneous pneumothoraces, bullous lung disease, but they can also develop bronchiectasis. And interestingly, these patients develop middle lobe hypoplasia. And why am I saying interestingly these patients have middle lobe hypoplasia? It's interesting because they also have other findings that we see in our patients that present with non-tuberculous mycobacterial lung disease. They have pectus excavatum, they have scoliosis, they have mitral valve prolapse, aortic insufficiency, aortic root dilation, and very similar to the patients that we see with chronic non-tuberculous mycobacterial infection, especially the pectus, the scoliosis, the mitral valve prolapse. And it's suggested that some chronic non-tuberculous mycobacterial patients may have a subclinical variant of Marfan's, leading to bronchiectasis. And the bronchiectasis here occurs because of weakness of the connective tissue or the bronchial tree. So, and one of the theories is that because these patients are tall, slim, they're very skinny, they have leptin deficiency, and it's been studied in mice that leptin deficient mice are more susceptible to MTB and Mycobacterium abscessus, which is very interesting, and possibly related to estrogen deficiency. So this takes us to the next question. 66-year-old white woman is referred to because of chronic productive cough and an abnormal chest X-ray. She was in good health until approximately 2 years ago when she developed recurrent episodes of productive cough. A variety of antibiotics were prescribed with apparent improvement in each episode. Over the last 3 months, she had 2 exacerbations of her respiratory symptoms, increasing fatigue, and a 3-kilogram weight loss. She never smoked. Her medical history is otherwise unremarkable. Physical exam reveals a tall, thin woman in no acute distress. Vital signs are normal. Chest exam reveals bilateral inspiratory squeaks. She has mild scoliosis and pectus excavatum. And here's the CT. And the CT is similar to what we showed earlier. You see this lingular involvement, bronchiectasis, cystic bronchiectasis in the lingula, and cystic bronchiectasis in the right middle lobe. This is the inferior segment, or the medial segment, sorry. And then you see associated bronchiectasis and mucus plugging in the remainder of the lungs. So the question is, which of the following is correct about the most likely cause of this patient's recurrent pulmonary and systemic symptoms? So A, they're associated with genetic, hormonal, and immune abnormalities. B, they're caused by a pathogen that is transmitted from person to person. C, the optimal treatment includes isoniazid, ethambutol, and a macrolide. Or D, recurrences are unlikely with guideline-directed therapy. Anyone want to take a gamble at this?
I mean,
All right, I will. Oh, somebody was speaking. Sorry.
I said A can never be wrong. Could apply to
A
anything.
can never be wrong. And Fiore, you are correct. A is correct.
Answer could apply to anything.
What was that?
That answer refers to any disease ever.
It's absolutely. Sounds like COVID, to be honest with you.
Sounds like I6 is your genetic immune abnormality.
Exactly. Yeah, this is, by the way, all these questions I'm giving you are from Seek, but I go by a process of elimination. Is MAC, or non-tuberculous mycobacterium, a pathogen that's transmitted from person to person? It's not. The optimal treatment is not isoniazid, but is ethambutol, a macrolide, and usually rifampin. And unfortunately, even with guideline-directed therapy, recurrences of non-tuberculous mycobacterial lung infections and bronchiectasis is very common. Okay, so we have another question. A 30-year-old man is referred for the evaluation of interstitial lung disease. He has a history of UC for the past 9 years. Symptoms were initially controlled with anti-inflammatory therapies, but due to refractory GI symptoms, he underwent a hemicolectomy with reanastomosis, resulting in significant improvement in his symptoms. Unfortunately, he developed an intractable cough with progressive dyspnea, and complicating his dyspnea is a daily cough productive of green to yellow sputum. He's been hospitalized every other month for the past year from recurrent infections, and he has Pseudomonas and MRSA colonization. And here you see on his CAT scan, you could see this bronchiectasis, diffuse bronchiectasis, bilateral, and you can see here, this extending all the way to the periphery with associated mucus plugging. The most likely cause of the patient's lung disease is A, cystic fibrosis, B, ABPA, C, UC, or D, primary ciliary dyskinesia. Who's here? Anastomy, Ryan, Ben. All right.
I feel like I'm cheating because I did Seek already.
Oh, Matt, yeah, and you took your board too.
Yeah, I know the answer, but I'll let one of the other. Yeah.
Well, we're muted just because I think we were causing some echo.
No
so I think
worries.
initially in the initial question I put A, but it's probably C because you can
C
get
is correct. Nice job,
IBD
Ryan.
associated.
And why did you pick C, Ryan?
Because you could get IBD associated ulcerative colitis, and it seems like, because I was thinking initially when I read the question, I mean, all the GI symptoms could be explained by CF as well, but they're telling you he has actually a history of ulcerative colitis, so that doesn't really make sense.
Okay.
So it's really by process of
And,
elimination. It's not ABPA, and it's definitely not primary ciliary dyskinesia. Because a primary
I learned this from Seek, though. I think even more so was after the hemicolectomy. There's a resurgence, or it can exacerbate or accelerate IL or bronchiectasis. Sorry, I didn't know that before I did Seek. Yeah.
Yeah, and that's the important point. Thank you, Matt. Thank you, Ryan. Good job. Yeah, so you would think that after the hemicolectomy and his improvement in GI symptoms that his UC would be gone, but actually there is a high prevalence of developing the bronchiectasis subsequently. So this takes us on to the autoimmune or inflammatory causes of bronchiectasis. I'm not going to talk too much about sarcoid, but usually this is upper lung involvement and usually is a secondary traction bronchiectasis and could also be secondary to extrinsic compression or the granulomatous inflammation of the airways leading to strictures and infections. Rheumatoid arthritis, I think it's very important to understand that rheumatoid has a high prevalence of causing bronchiectasis. Up to 35% of rheumatoid arthritis patients who have a CT chest will have bronchiectasis. In fact, up to 50% of patients who are diagnosed with rheumatoid arthritis who have bronchiectasis will have had the bronchiectasis prior to being diagnosed with RA. And the etiology is either related from the immunosuppressed state from the RA or from the immunosuppressed medications. Ankylosing spondylitis is usually an upper lobe predominance with associated lung restriction associated with MAC. I'm going to leave these pictures for you to look at later. Lupus has a high association with bronchiectasis, up to 20% of lupus patients. And it's very important in these patients with autoimmune disease, for example, lupus, who have bronchiectasis, to look for comorbid Sjogren's. Sjogren's also has a high prevalence of bronchiectasis, and it can occur in conjunction with rheumatoid arthritis and in conjunction with lupus. These patients with Sjogren's may also have LIP or lymphoma and pulmonary hypertension. IBD, like we just talked about, UC much greater than Crohn's, and like we said, may develop after therapeutic colectomy. And lastly, relapsing polychondritis, where patients develop inflammation, weakness, and deformity of the cartilage, and develop bronchial damage and secondary infections with pneumonia with bronchiectasis over time. Here's a case of relapsing polychondritis, and you can see the thickening of the cartilage in the anterior and lateral trachea, and you could see excessive tracheal collapse with a forced expiration. And this, excessive airway collapse and distortion of the cartilage and inflammation results in recurrent infections and the bronchiectasis. Lastly, we have the last associated condition is oropharyngeal aspiration or GERD. And it's very important in these patients with bronchiectasis to look for associated gastroesophageal reflux. Sometimes these patients will need pH manometry. Sometimes these patients, especially if they have hiatal hernias, surgery may be therapeutic and may help improve their bronchiectasis symptoms over time. Lastly, post-obstructives, this is foreign bodies, tumors, and extrinsic compression. Very importantly, if somebody has focal bronchiectasis, these patients usually require bronchoscopy to exclude foreign body if there's no evident cause. So here's another question, and this is going to be, I think, one of the last questions. And then we'll finish. A 45-year-old man with a 20-year history of increasingly difficult to control asthma is seen in the clinic for ongoing wheezing, shortness of breath, and chest pain. His current regimen includes a budesonide formoterol inhaler and as-needed albuterol. Lately, he's been using his rescue inhaler 4 to 6 times a day and is waking up at nighttime. He's a non-smoker, lives in a carpet-free home. He's an insurance salesman. He denies fevers, chills, sweats, weight loss, or hemoptysis. And here's the CAT scan. And I hope by now, after all the images I've showed you, that you can clearly identify the abnormality here. And you see these tubular branching opacities and these dilated airways. It's very, very thick and hyper. You can see this hyper uptake on mediastinal windows because of the dense mucus plugging. On physical exam, he's no acute distress. Respiratory rate is 20, heart rate's 90, blood pressure is normal, oxygen saturation 93%. He has diffuse wheezing, and his white count is 10,000 with 12% eosinophils. And his chest X-ray shows a left lower low opacity in the CT, like we just discussed. So the diagnosis here we all know. In addition to beginning prednisone for this exacerbation, what is the next best step in his evaluation? Order testing for IgE, send sputum for AFB, perform bronchoscopy, or send blood sample for ANCA. They're saying A. All right, perfect. So yes, so this is A. What was it?
No, I see.
No, the big A sign. All right, perfect. So yes, you guys are on it. This is actually a patient of Dr. Steinberg, and this is a PFT. It doesn't look like the PFTs we have now because this is from about 20 years ago, I believe. And here you see this is the predicted, and then you see here the actual. And the patient had severe, or actually I think it was moderate, obstruction on PFTs without reversibility. Here you could see the X-ray. You could see here the dilated airway, especially in the right upper lobe. And this is the CT. And I think it's important to recognize the central bronchiectasis pattern that we see with ABPA. You can see the varicoid bronchiectasis here, the central bronchiectasis. You can see this area of mucus plugging, the branching opacity. You can see it better here on the coronal film. This is a patient who had ABPA. I think I'm going to skip this just because of the time, because we have to finish in a couple of minutes. But I think it's important to know the diagnostic criteria, so I'm going to put them right here. So you have to have a predisposing condition, so either asthma or CF. And then you have to have either Aspergillus skin testing that's positive or IgE against Aspergillus fumigatus, and an IgE that's greater than 1,000. Other criteria you have to have at least 2 of 3 of these is presence of precipitating or IgG against Aspergillus in the serum. You have to have radiographic opacities like we described, and hypereosinophilia at least greater than 500 in a steroid-naive patient. Of course, a lot of these patients are already on steroids, so their eosinophils may be normalized. But you want to, in a steroid-naive patient, you want to see eosinophils greater than 500. And again, it's good to see a lot of images. Here you see the branching tubular opacities and the bronchiectasis, the central bronchiectasis. Here's just more images to look at the same. You see the very thickened airways, the bronchiectasis central, and the varicoid bronchiectasis. And then again, you want to see here the classic mucoid impaction and the high attenuation here on the abdominal or mediastinal imaging. Treatment, and this is always on the boards, oral prednisone, at least half, 0.5 to 1 milligram per kilogram per day for 2 weeks, then taper. They should be on inhaled corticosteroids. And then very importantly here, and this is always asked, is addition of itraconazole. Treat for 6 weeks, and this helps reduce the amount of oral prednisone that these patients require. Monitoring, the best way to monitor is with IgE. Total IgE levels should decrease with therapy and is the most important variable to look for in tracking course of disease, but also important is symptoms, PFTs, and the peripheral eosinophilia, along with improvement in imaging. If I can do 5 more minutes and then I'll be done. I'm going to skip these other causes. I'm going to actually just skip this question for now. But in the diagnostic evaluation of these patients, like we said, CT is very important, PFTs, a complete blood count. Some people like to measure ESR and CRP to measure for non-specific markers of inflammation. But a sputum culture is mandatory in anybody who has symptoms of bronchiectasis with associated findings on CT. And a sputum AFB is mandatory. And these cultures should be done serially. And of course, with any exacerbation, a routine sputum culture should be performed. In patients who have chronic rhinosinusitis, a CT scan of the sinuses may also be helpful in diagnostic and possible therapeutic implications. Other specific directed studies, we talked about measuring for cystic fibrosis, alpha-1 antitrypsin, immunoglobulin levels, and actually the British Thoracic Society and the European Respiratory Society both recommend checking immunoglobulin levels in all patients and IgE levels as well in all patients. And then specifically if patients have symptoms of acid reflux, barium swallow or a pH manometry may be important. And then in patients who have risk factors for autoimmune or collagen vascular disease, checking specific serologies, rheumatoid factor, CCP, ANA, Sjogren's may be important. I'm going to skip this because we kind of talked about this in our talk. We talked about this. All these slides will be available. It's just there was a lot to talk about, but kind of going with everything we talked about. The management of bronchiectasis, the 5 hallmarks of therapy is airway hygiene, antimicrobial treatment, anti-inflammatory therapy, possible surgery or lung transplant, and then other miscellaneous things. I'm going to skip the question. But airway hygiene, there's so many different forms of airway hygiene. None of them has been shown to be superior to another, especially in non-CF bronchiectasis. They're not as well studied. But the a cappella devices, the flutter devices appear to be the most tolerated by patients. And patients seem to like these flutter a cappella devices much more than they like the vest. But the vest has, can be very helpful in augmenting mucociliary clearance in patients who have severe, chronic, purulent, productive sputum. The vest may be helpful for them. Other methods, inhaled beta agonists. You want, hypertonic saline or even mannitol is being studied to help bring up these thick secretions, help loosen them up and bring them up. Very importantly, and this is always on the boards from what I remember, pulmozyme is no longer given in bronchiectasis, in non-cystic fibrosis bronchiectasis. And let me actually go to this 1 second. I didn't realize this at the time, but I found this paper, this hallmark paper of looking at DNase in non-cystic fibrosis or idiopathic bronchiectasis. And one of the authors is our very own Dr. Illoway. This is a paper back from 1998 in Chest. And they found that treating these patients with DNase was shown to have increased exacerbations and lower FEV1. And so, all the guidelines now recommend against giving DNase as a mucolytic in patients with non-cystic fibrosis bronchiectasis. Antimicrobial therapy, I think it's very important to use sputum culture and sensitivity to guide antibiotic choice. And some people will give prolonged oral antibiotic therapy. It's important not to give too many different forms of oral antibiotic therapy just for resistance. but it has not been shown to be beneficial in improving lung function or decreasing exacerbations. A couple of key points: avoid azithromycin if they have concurrent non-tuberculous mycobacterial disease. We do give a lot of these inhaled antibiotics. They're not as well studied in non-cystic fibrosis bronchiectasis, but there are a lot of studies, and we have inhaled tobramycin, we have inhaled gentamicin, we have inhaled colistin, and more recently with the Respire studies, we have inhaled ciprofloxacin. And a lot of these have been shown to decrease the microbial burden and may improve sputum production. But unfortunately, a lot of them don't show benefit in terms of decreasing FEV1 or decreasing. They do help decrease exacerbations, actually. So I do want to point out here a couple of things. First of all, if Pseudomonas is present, a 14-day course is standard of therapy. It's important to do this 2-week course. In fact, for any bronchiectasis exacerbation, an initial bronchiectasis exacerbation, a 2-week course of antibiotics is recommended. One other thing that's important to note is some patients may respond to antibiotic treatment even if there is in vitro resistance, and the recommendation is to only change antibiotics if there's no clinical response. When do we use antibiotics? If there's greater than or equal to 3 exacerbations per year. If you have Pseudomonas colonizing the airway, you can use inhaled colistin, gentamicin, or even possibly inhaled cipro, although that's not currently available quite yet. You can use azithromycin or erythromycin chronically as an alternative, or even as in addition to inhaled antibiotic if the patient doesn't tolerate inhaled antibiotics, or if the patient has persistent symptoms despite inhaled antibiotics or persistent exacerbations, you can add azithromycin to their therapy. If a patient does not have Pseudomonas with greater than or equal to 3 exacerbations per year, start with azithromycin or erythromycin, and then if they continue to have exacerbations, you can use inhaled gentamicin. In patients who can't tolerate macrolides, you can use doxycycline. 3 key points here I wanted to talk about. Before starting inhaled antibiotics, they recommend doing a bronchial challenge, making sure they don't develop severe bronchospasm. A lot of these inhaled antibiotics will cause wheezing, and so it's one of the more common causes for stopping inhaled antibiotics. Before starting macrolides, rule out non-tuberculous mycobacterial infection. And then before starting inhaled aminoglycosides, avoid it if the crank clearance is less than 30. Always check a hearing test. And of course, with macrolides, also always check a hearing test first and avoid other nephrotoxins. This is just in a diagram form. If chronic, you can do hearing, if they have hearing issues. All right. I think I'm going to stop. I'm going to stop there, but if you guys have any questions, I'm going to share the PowerPoint with you guys. I did at the end over here include all the guidelines from ERS and BTS, including the different antibiotics that are used for the different bacteria, including MRSA and Pseudomonas. And then I also wanted to show you, all the guidelines from BTS and ERS. I included the main images or the main tables here for you guys to have. Any questions you guys might have? Sorry, that was a lot of information.
Great. Thank you. It was so thorough and really well presented. I don't have a question, but I really just want to thank you.
Oh,
Mina, I want to thank you as well. We're watching from 410. That was the most comprehensive bronchiectasis talk I've ever heard. And if Dr. was on vacation, he would say presenting his paper as well.
Thank you. All right, I'll share this with you guys.
Thanks, Mina.
Thanks so much, Mina. That was great.
Thanks.
Take care, guys.
Okay.